Okay, let's start with this case. So here we have the clinical history. He is a 42 years old Caucasian male with a chronic kidney disease with a 1.6 of serum creatinine and 52 milliliter per minute of eGFR. He has a nephrotic range proteinuria with 7.3 grams per day of protein in the urine, but his albumin is quite good, 3.5, so he is not nephrotic. He has a normal serum electrophoresis. He is obese. He has a past medical history of psoriasis and 2 previous episodes of gross hematuria during infection. So this biopsy was referred to us by an outside hospital. So let's start with the light microscopy. So we have here different stain, PIS, H&E, Congo red and silver. Let's start with PIS. So this is a low power view of the biopsy. We have a core of cortex. Let's go on full screen. Okay. Core of cortex, we can count several glomeruli. 1, probably 2 here, globally sclerosed. 3, 4, 5, 6, 7, 8, 9. Here we have another one which is globally sclerosed or obsolescent. 10, 11, 12, 13, 14 glomeruli in this section. 2 of them are obsolescent. So with this low power we can say also that there is some kind of chronic injuries also in the interstitium. We have fibrosis. We have a certain amount also of tubular atrophy. I would say which is around 1/3 of the biopsy, which has tubular atrophy and interstitial fibrosis. So now let's go and we will take a look at close at higher power to the glomeruli. So what we can say about this glomerulus? For sure we can appreciate an expansion of the mesangial area, which is characterized by this deposition of past positive material with some degree also in some field of mesangial hypercellularity. Capillary loops look okay. I don't see endocapillary proliferation, at least in this glomerulus. Let's go and see more of them. Here again we have expansion of the mesangial area, increase in this PIS positive material, some degree also, although here we are close to the vascular pole, of mesangial hypercellularity, and this again increase in the mesangium, some degree also there are some mesangial areas that have more than 3 nuclei, so there is mild mesangial hypercellularity, no endocapillary proliferation so far. So if we remember the clinical history of this patient, he had 2 previous episodes of gross hematuria, and he has now nephrotic range proteinuria, and he has also psoriasis in his past medical history. So with this feature, at this moment, my first diagnosis, waiting for the other study in fluorescence in electron microscopy, would be for sure IgA nephropathy. Let's go and take a look at the vessel. There is a mild thickening of the media of this small artery here. It's a small, or an arterial with the thickening of the media. Here we have an area of interstitial fibrosis with a tubular atrophy. We have also an obsolescent glomerulus here. No crescent, no endocapillary proliferation. So if this was an IgA nephropathy, this would correspond to an M1S0. So far we haven't seen segmental scarring in the glomeruli, and E0 T probably 1, and C0 we haven't seen crescent so far. So we want to take a look at another section, and we have same feature here. Oh, here we have a glomerulus which has at least 2 areas of segmental sclerosis of the tuft with hyalinosis and addition to the Bowman's capsule. So we have a lesion of segmental sclerosis in this glomerulus. Okay, let's take a look at another stain. Let's go on the silver. Let's go on full screen and let's see what we have. I would say that this silver is a little bit too dark for my taste. And anyway, we can see that there is an increase in the mesangium again. Although this silver, as I was saying, it's a little bit too dark, we can appreciate that some of these mesangial area are only weakly silver positive. So no endocapillary proliferation. I don't see subepithelial deposits. I don't see spikes at this resolution. So we have at the glomerular level, the changes are mainly confined to the mesangial area. We have accumulation of this PIS positive and only partially silver positive material in the mesangium, with some degree of mesangial hypercellularity and a lesion of segmental sclerosis that we saw on the PIS. So let's go and take a look at what the immunofluorescence in this case show. This is the IgG, which is positive. We have at least 3 glomeruli here, and I think that we have a higher magnification here, and the pattern of this staining is quite peculiar, and it's not granular, it's not linear. It is defined as a smudged, and it is mainly in the mesangium, as you can see here, and also some portion of the capillary loops are also staining positive. IgA and IgM were negative in this case. We do have C3, which is positive. It's probably a partially sclerosed glomerulus, but it's stained positive. C1q was negative, and kappa and lambda were staining positive with the same intensity. So this pattern of positivity for IgG polyclonal is highly suspicious for fibrillary glomerulonephritis. And in this case, we didn't have tissue initially submitted for electron microscopy. So we went back and reprocessed for electron microscopy the tissue fixed in formalin and included in paraffin. And this is what we found. Of course, we have some artifacts which are linked to the reprocessing from paraffin. This is a low power of a glomerulus, and it showed this stuff, this material here, which is mainly in the mesangial area, and there is also some of this material here in the subendothelial space. And if we go to the higher magnifications, we can appreciate the fibrillary organization of these deposits. We have randomly arrayed fibrils, mainly in the mesangium, and you can see here these fibrils, and here the higher magnification, these randomly oriented fibrils. And if we measure these fibrils, probably we have a picture, we can see, although we are measuring tissue reprocessed from paraffin, and so the measurements are not very reliable, we have a length of this fibril around 20-22 nanometers. So putting together these findings by light microscopy, immunofluorescence, and electron microscopy, we have a mesangial expansion by light microscopy, accumulation of this eosinophilic, PAS positive, weakly silver positive material in the mesangium, which stains for IgG, polyclonal, and C3 with fibrils on electron microscopy. These findings are highly suspicious for fibrillary glomerulonephritis. But to call this fibrillary glomerulonephritis, we need to rule out amyloidosis. And we did Congo red staining in this case, and we have here Congo red was, as you can see, negative within this area. So this was a case of fibrillary glomerulonephritis.